Thanks for coming to the session today. It's estimated that 2 out of 3 healthcare dollars are spent on chronic disease. A lot of this is lifestyle-related diseases, diabetes, obesity, and it's not easy just to give people a pill for that. In my reporting, I've been looking around a lot at the innovative approaches that some healthcare companies are trying, and I stumbled upon something that I'm wondering whether it's becoming a new trend. About 3 years ago, I went to central Pennsylvania to a Geisinger health facility. They had enrolled about 150 people who had elevated A1C, many of them uncontrolled type 2 diabetes. They basically said to them, we are going to give you fresh food for an entire year. And not only are we going to give you fresh food, but when you come to pick it up every week, we're going to teach you how to make healthy meals with it. And we are going to let you work one-on-one with a registered dietitian. And we're going to have social and social cooking demonstrations. And we're going to help you in 15 different ways try to change the way that you eat. Interestingly, I met a man named Tom Shokovich. He was 56 at the time. He has now lost 100 pounds working with this intervention. And he said to me, you know, I knew for a long time that I was overweight and not well. And the doctor would say to me, you need to lose weight. But nobody ever told me how to do it. And he also said he didn't even know that his diabetes and his complications, including an amputated toe, were directly correlated to being obese. He just had never been given that information. So this program at Geisinger Health is kind of interesting. It's a pilot, but what Geisinger found is that for every 1-point drop in hemoglobin A1C, which is a long-term measure of blood sugar, you would see about an $8,000 reduction in healthcare costs. Now, it was a short-term pilot, so it's hard to know if those results would hold up over time. But to me, it was a very powerful example of the kind of intervention, the kind of lifestyle intervention that could possibly move the needle here. And interestingly, in the Farm Bill in 2018, Congress passed, as part of the Farm Bill, Congress allocated a whole bunch of money for these food pharmacy pilots around the country. So I think we'll be hearing more of them. I want to start with Anand. Do you think that this kind of intervention that Geisinger tried is likely to be the kind of thing to take off or something we'll see more of in the future?
Allison, thank you for that question. I think there's certainly a tremendous need. And this is a pretty innovative program, as Allison mentioned. It's food pharmacy, but it's not spelled pharmacy with a PH, it's spelled with an F. And one of the things in a prior life when I was at Health and Human Services, we talked a lot about when it comes to tertiary prevention of chronic diseases and chronic disease management, it's really important that you match the acuity of the individual with the intensity of the intervention. So here in Geisinger's case, that's what they did. So these are pretty poorly controlled Americans with diabetes, high hemoglobin A1Cs, who have screened positive for food insecurity, which we know is a tremendous challenge in this country. So high acuity, high risk individuals for preventable hospitalizations as well as emergency department visits. And then the intervention, as Allison mentioned, is pretty intensive. I mean, these are meals for the family twice a day, every day, 5 days in a week, plus diabetes self-management training. So it's not just sort of a nurse or a social worker or somebody calling the patient at home. So when you can match the acuity of the individual to the intensity of the intervention, when we've looked over the last 15 years is how well does Medicare do in chronic disease management, tertiary prevention? What's the best way to improve outcomes and reduce costs? It's doing this matching. And I think one of the reasons why I think Geisinger's initial pilot studies and results are so promising is because they've done exactly that. So I think in short, a very promising intervention, and there's substantial need out there given the millions of Americans who have uncontrolled diabetes and who have food insecurity as well.
Tom, I want to move on to you from a more of the payer side perspective. I know in this case of Geisinger, in this particular case, the man who I told you about, Tom Shokovich, he had a toe amputation, ended up with sepsis, and was in a critical care center for 6 weeks on intravenous antibiotics because he lived alone. This intervention cost about $200,000. The cost of giving people free food is $1,000 a year. Talk a little bit about whether, in the end, these kinds of savings, again, you'd have to see them year after year, could move the needle.
So my hope is that they, excuse me, that they can move the needle. Geisinger is in a unique position in that it is a relatively isolated area in a town where there is one main provider, and they are also the largest health insurer in that town. And so they are able to embrace a program which looks at patients over a longer period of time, because at some point they will be responsible both as a health system and probably as a payer, or the employers in the community will be responsible. So the idea of having an intervention that is targeted, highly intense, and at first glance effective makes a whole lot of sense. What we see in other parts of the country is a highly mobile population, either mobile as an insured population or simply mobile from job to job, or mobile physically. So trying to identify those patients and then do an intense intervention becomes very difficult. The other thing which I just want to note is the difference between fee-for-service and capitated environments. So if you are in a fee-for-service environment where you're paid as a provider for every service as you go along, the services for a diabetic, and particularly for a severe diabetic, where you're trying to make a lot of lifestyle modifications, may not be reimbursed. Altered that with a capitated environment, particularly for Medicare, where there's a provider group which is taking care of that patient in any way. So moving those services to a lower cost nutritionist or behaviorist or instructor in food may be a great place to go, and is the natural thing to do, but not natural for those in the fee-for-service environment.
The Affordable Care Act actually considered nutrition counseling as an essential benefit. Have we seen more of that, moving it out of primary care down to a level of working with an RD or working in a community setting, maybe working with a diabetes prevention program that is scaled to a level that is a lot more affordable, say in a YMCA? Have we seen more of this?
Not enough. Not enough. Where you see, what you still have for many people is a primary care provider who is dealing with whatever's right in front of them, and the chance that they are well coordinated with a nutritionist or a nutrition program is pretty low.
So Nancy, when you think about moving programs to incentivize, wellness, or to incentivize behavior change, getting people to eat differently, getting them to move, outside of the four walls of the doctor's office, where do you see sort of the innovations in this, using a sort of more community model? We hear so much about the social determinants of health, how health happens in schools and communities. Where do you see innovation happening? Yeah. Or do you?
Oh, I think there's a lot of innovation happening. And, it's really interesting. I hope one thing I can do in this discussion today is to bring the point of view of the person, the patient, the person who's suffering from these illnesses. And in the case of the gentleman with diabetes, my guess is that he, since he didn't have a family, that he desperately wants to be well and not to be sick. And it's a shame in this country that things like payment models, get in the way of people having the services they need, especially when we know that food is such an important aspect of managing diabetes. And so I'll just say that to start. But from our point of view, we need to couple services in communities with our healthcare providers. And you mentioned the diabetes prevention program in the YMCA is a wonderful example, and we work very closely with the YMCA, so I can tell you that this is a wonderfully effective program that takes away the formality for people who are suffering with diabetes. And, we see in our work at the American Heart Association, patients on the ground are looking for solutions. They want access to healthy foods. They want places that they can get physical activity. And the question is, how do we mobilize our communities to make it happen?
And Paul Davis, as you listen to this conversation, your company is looking at areas that typically are undercapitalized in terms of R&D development for new pharmaceuticals, interventions. Do you think there's a role here for pharma to play in coming up with interventions that can help these lifestyle diseases?
Absolutely. I mean, we've just heard about the importance of making targeted interventions in the form of lifestyle. The same is true for therapies. You want to make sure that the right therapies are reaching the right patients. And part of that is ensuring that there's access to data across the system. I mean, right now, your healthcare data is spread across probably 200 different sources, whether it's payer data, claims data, whether it's your physician, your previous physician, your pharmacy, even your consumer data, which is obviously implicated in diabetes in terms of purchasing power. I think all of these are areas where it's very challenging today for any one person to control all of that in a way that enables them to make the right decision for themselves. Genotypically, what is the best therapeutic intervention for them? And I think we're trying to make that easier, and I think that's a challenging thing to do while still respecting HIPAA. But I think it is an area where there's a lot of room for growth. The same thing with aligning incentives. I mean, we talk about the importance of incentives. I agree with Nancy. I think patients have a lot of incentives to avoid progressing in these disease states. And really, even the concept of having them skin in the game in the form of copays is a little silly. They have a lot of skin in the game. And I think that's almost...
Everybody wants to be well.
Absolutely. And it's criminal that people are unable to access therapies because of their inability to pay, especially for cheap generic therapies like insulin. But I think the same is true in terms of incentives for drug development. We want to make sure that instead of incentivizing the development of therapies that are chronic, where you get paid every year as a result of this patient being on it for the rest of their life, we actually are incentivizing transformative therapies, whether that's gene therapies or cell therapies, things that actually have the potential to not just sort of modify the course of the disease, but actually cure it. And I think that's an area where thinking about creatively about value-based pricing can be a way to ensure that the industry, as we're developing medicines, is developing medicines that patients actually want, which are not incremental, but rather transformative.
Got it. I want to go back to the idea of sort of primary prevention. So the Geisinger program really looks at people who are already in a disease state. Where are the innovations sort of in thinking about primary prevention? We already talked about the diabetes prevention programs. Those, of course, came out of the big DPP trials that were done 15 years ago around the country. I'm sure a lot of you already know those results, but basically at the end of many years, they found that lifestyle intervention was more effective than metformin at stopping the progression from prediabetes to type 2 diabetes. So when you take that model of the diabetes prevention programs where you capture people when they're a little bit overweight or maybe their A1C has climbed just a little bit into an unhealthy level, what are the best approaches to sort of scale these prevention measures that we know work to the whole population? We talked about the YMCA, but I gather that there are a lot of electronic programs as well.
Yeah, I might pop in on that. Elevated high blood pressure is one of the highest risks for people having a heart attack or a stroke. And of course, cardiovascular diseases are the #1 killer of Americans, and 17.5 million people globally lose their life a year due to cardiovascular diseases. And so we've been working at looking at every step of the journey for someone who may be at risk for elevated blood pressure, all the way to people who are diagnosed. So how can we inspire physicians to know the new guidelines? In case you didn't pay attention, a couple of years ago, 110 million people woke up and found out they had elevated blood pressure because the guidelines were changed to reduce what had been a long-standing measure for high blood pressure. So we needed to educate physicians. We do that through a program called Target BP, which is exactly using technology to link the electronic health record and study the longitudinal blood pressures of patients in the doctor's office or in a healthcare system as they're being treated. But also then, how do we inspire the individuals to be managing their blood pressure through lifestyle changes, which is what our guidelines talk about initially. We need lifestyle changes, more exercise, better, more healthful diets, not smoking, all of the things that you would imagine, but also the ongoing monitoring outside of the office. And so we've published a number of studies. And we did one with Kaiser Permanente in Colorado that has had a lot of publicity about the power of the out-of-office management of blood pressure for individuals. And so we're looking at that all along the way and making sure that we can thread that from the patient or the consumer, because these are before people are even patients, right, all the way through the healthcare system.
And it seems like empowering people to feel like they own their health, that they could be in charge of their health is an important part of this.
Yeah, and with all the new technologies, whether it's measuring data on your smartwatch, your phone, there's so many ways that individuals can be inspired, and what we have to think about is how those technologies are accessible by people who can't afford a $300 watch,
right.
And how we make sure that that happens.
Anand and Thomas, I wanted to hear two different perspectives on a program put out by a company called Omada Health. It has basically adapted the DPP program, the Diabetes Prevention Community Program, programs to more of an electronic format. Talk a little bit about whether you think that's helpful. Are you able to reach more people this way? And might we see more insurers willing to pay for programs like this one? I know there's a lot of similar programs.
So Omada Health or Livongo or a bunch of other companies are really doing an interesting job of matching monitoring to feedback loops and trying to change behavior by having people interact more frequently and in a very personalized way with these systems. I think it's way too early to say whether they work and for how long they work. And the earlier comment about stratification of the population, so for severe diabetics or uncontrolled diabetics, I think that they're definitely showing an impact. Whether they are able to show an impact for those who are earlier on in the onset of their type 2 diabetes, unknown, and the question over time, unknown, all of which is to say, this is great, let's engage in this, let's see how it works, and there are more paying for it than used to.
Yeah, I mean, is the big struggle, you think, unlike a medication where you can see that the intervention works and sort of continues to have an impact, with behavior change, is the struggle that people have to keep doing the good behavior, they have to continue swimming upstream in a society that is not overall eating well or being very active?
Absolutely. So diet and exercise, easy words to say, very hard things to do, and particularly hard things to change and maintain over a period of time. So everything which we can do which helps incent that and change the behavior, particularly at the margin, is a wonderful thing. But prescribing it is a start. Following up and monitoring it is a continual effort. And then figuring out over time how you have to change it to keep people engaged is still an unanswered question.
So Anand, just that idea that easier said than done.
Sure. Well, I think that the question of how do you scale evidence-based chronic disease prevention programs is a really important one, and I think the diabetes prevention program provides sort of a case study in many ways. I was at Health and Human Services over 10 years where that program started as an NIH clinical trial, then translated into the community. CDC set up a recognition program. Then the Innovation Center at CMS tested this for Medicare beneficiaries, and the actuary at CMS eventually said that this program will not only improve health but reduce costs, and it was scaled. And so I think one of the ways you scale programs like this, so it's not dependent just on discretionary grant dollars or philanthropic dollars, is really to tie it to sort of mandatory programs. But then there are two additional issues. The first is prevention often requires promotion and communication and marketing. It's not as if you build something, people will come for sure. And I think there was a recent Politico article about this. One of the disappointments so far with the diabetes prevention program and CMS is the uptake has been relatively low. And some of that has to do with providers as well as patients not understanding much about this benefit and where to go and the efficacy of this. So I think how you communicate sort of evidence-based prevention programs matter. I think the issue about online programs is really a program integrity issue. And I think the concern at CMS is likely, if you have individuals specifying their weight loss over time, is this correct? How do you make sure that there isn't fraud, abuse, and waste? I think my response would be, look, these are challenges that are not new. They have been overcome. I think it requires leadership as well as commitment. Omada and other online platforms actually have shown that their results are as good as in-person programs. And so if the issue is program integrity, let's deal with that. But we need to make sure that there is a commitment to prevention. There's a commitment really to expand these programs to millions of Americans who might not have the transportation to go to the YMCA, or who might not be able to go, or who might not feel comfortable in a group setting to benefit from this evidence-based program. So we need to provide multiple modalities to Americans out there so they can all benefit from these very important programs.
Nancy, what do you think about, this is a bit of a left turn, moving from sort of policy efforts, a little bit more from, it's a little bit of carrot to stick. Your organization has been very supportive of taxes on sugary drinks as a policy lever to change people's behavior. Talk about why you support that.
Yeah, happy to talk about that. And absolutely, we recognize first, just to say that a child under the age of 18 generally drinks their age in sugary beverages a week. And so if you think about dietary guidelines, including the dietary guidelines of the American Heart Association, people are consuming too much added sugar, and we know that added sugar increases your rate of obesity, type 2 diabetes, and you're creating a lifelong habit that ends up with the problems like we talked about with the gentleman in the Geisinger system. And so as we think about ways to make these sugary beverages not accessible to kids. And if you look at what's happening by many of the beverage companies and their parent organization, you will see a lot of targeting of sales of sugary beverages to especially underrepresented minorities in our poorest communities. And so we believe that a range of programs have to be in place to remove that access to kids. And so taxation is one of many strategies that we support at the American Heart Association. We recognize that even the idea of talking in a community about removing access raises awareness of parents and community members about the harmful effects of consumption of sugary beverages by America's youth. And we also recognize that these lifelong habits that are developed are creating this bottleneck in the healthcare system. We know from decades of work in tobacco, where the American Heart Association has been a leader along with other partners, that taxation is an effective strategy to remove access to youth, and that really is the priority of the AHA.
Got it. I want to move on to an example of a transformative intervention you might be working on, but I just wanted to get your response down there. I mean, when you hear these kinds of policy levers, a soda tax, for instance, do you, from the bipartisan perspective, is there bipartisan support for these kind of things?
Well, we had a bipartisan task force that actually looked at the SNAP program last year and issued recommendations, and in fact, one of the recommendations was that sugar-sweetened beverages shouldn't be part of the program. Now, I think there is some modeling that suggests actually a broader view where you incentivize healthy products and disincentivize unhealthy products might actually get you the most bang for your buck from a health and cost perspective. But I think, as Nancy is alluding to, there is increasing emerging evidence that taxes on sugar-sweetened beverages that don't have any nutritional value do, in fact, reduce sort of purchases, reduce consumption, at least of soda for adults, and in terms of kids, at least kids who are drinking quite a bit. There's some improvements related to health disparities as well. And as Nancy said, just like with the tobacco tax or alcohol tax, you know what's going to happen here. So I think it's a really important point that to tackle chronic diseases in this country, clinical interventions are going to be critical, but they have to be surrounded and reinforced by policy systems and environmental changes that are evidence-based, that can reinforce what we're doing within the four walls of the clinical setting. Only when we're focusing on both within the four walls and outside the four walls together synergistically will we really be able to tackle the chronic disease epidemic.
And Tom, do you hear that from the payer perspective? I mean, inside health companies and payer systems, are they saying, look, what are we supposed to do here? Like, the reason why people are coming to us with these diseases is what's happening out there. Is there a sense of like, please help us with community interventions?
So I'm from Atlanta, where every church, synagogue, and university is funded by a sugary drink.
Wow.
So I have to be a little careful. So the answer is yes. Policy touches everything. As we get into a discussion maybe later about social determinants, those are not healthcare system treatment questions. They're how do you go upstream and how do you create lower incidence. So we see employers vary in how much they're willing to engage on those things and probably need to be a little more articulate. I think your CEO council has been more articulate in those issues than most of the smaller employers we have dealt with.
Got it. And Nancy, talk about your CEO roundtable, what you learned when you gathered a lot of CEOs around the table and said, hey, what do we do here to move the cost curve on healthcare costs, particularly chronic disease?
Yeah. So by background, we have a roundtable of about 50 CEOs of America's largest companies, as well as diverse companies, to make sure we have representation by industry. And we created this roundtable several years ago. It actually coincided with the launch of the Affordable Care Act, because at that time, many CEOs with whom we interact on a regular basis had a lot of questions. You know, healthcare used to be an HR issue, and suddenly on investor calls, the CEOs were getting a lot of questions about health and healthcare, and we wanted to add value to their knowledge base. And so we created this roundtable that was initially chaired by Henry Kravis, the co-CEO of KKR, and Terry Lundgren, the CEO of Macy's. And we gathered together a number of CEOs who shared our mission and our value to think of the patient or the customer first in designing engaging ways to think about health and well-being. And so this roundtable now, several years later, is about 50 organizations, chaired these days by Brian Moynihan, the CEO of Bank of America, and Alex Gorski, the CEO of Johnson & Johnson. And the focus of the roundtable is really making sure that we start with the employee and their family and the community. And what is it that will inspire health and well-being among, you know, our employees and in our communities? And we've done extensive surveying about the things that employees want that will engage them, especially younger people, in their health and well-being. And we use the roundtable as an incubator to test many of these solutions that are technology-based.
And what do they want?
They want, you know, first of all, they want modeling from their CEOs and people in their C-suite around health and well-being. They want access to technology-based interventions. They want, you know, they want to connect with the community, but they also want attention being paid to the cost of healthcare for them as the employee and more transparency around costs. And so the great thing about the roundtable is that we're peeling away some of these issues, because the thing we don't want this to be, and it's not because these CEOs are not focused on this, you know, if the cost of healthcare can be driven down for the employee and the employer, and money reinvested in prevention programs and things that really matter to employees, that's a real win-win. And so one of the things we're focused on right now with the roundtable members is looking at high-value services and making sure we're providing maximum incentive for the highest value services that include a lot of prevention activities, and really shining a light on things that we at the AHA would say are low-value services. And so how can we help companies think about designing their programs so that we're maximizing no cost or low cost, including premiums, deductibles, co-pays for things that will have the greatest value, and removing a lot of money that's being paid on things that may not, based on the evidence, have as much value, and think about how those freed up dollars can inspire more prevention in our companies. The other thing I want to say that employees want, and the roundtable is very focused on, is mental health and well-being, and how do we connect the, you know, the mind to the rest of the body, and not just think about physical health, but mental health. And so we are doing extraordinary work in this area, and really trying to reduce the stigma of mental health. We just did a survey. 74% of employees say that they come to work every day with anxiety, depression, stress, you know, so these are real factors that impact whether or not people are going to care enough to eat healthy and exercise.
There's a big overlap between, just talking mind, body, health, there's a lot of overlap between these feelings of anxiety and depression and the risk of addiction. So opioid addiction, for instance. The American College of Physicians came out several years ago, I want to say back in 2015, and said, look, when it comes to managing chronic pain, we need to move people away from opioids, which we've, of course, have been hearing this for a long time now, and we want to have non-pharmacological interventions. We need to look at the evidence base behind yoga, physical therapy, acupuncture, you name it, a whole range of sort of lifestyle interventions, anti-inflammatory diet, biofeedback are a few more that came up. I'm just sort of wondering why it is that, what are the obstacles to moving in that direction, Tom, from a payer perspective? I know that recently there was a study published that found, despite these recommendations to try to move patients into these interventions, they're largely unpaid for. Physical therapy, yes, but some of the other ones I mentioned, no. And oftentimes therapy, talk therapy, can be as effective as some of these other interventions, but patients finding it a hard time to get that paid for as well. Just talk about why that's so difficult.
So let me talk about it from two perspectives. One is the practice model. And I'm going to steal from a prior panel, which I thought made this very clear. They talked about a patient who comes in and says, I've been depressed and my back hurts. And the doctor says, well, tell me about your back.
Yeah,
and,
right.
And I'm stealing that from another session, which was really quite good. And so I think we're starting to see practices organize where they have an integrated model of behavioral health and medical practice, so that when that statement is made, they say, I'd really like you to meet my colleague here, and we can talk about these issues, and then we can address your health. Payment for that has improved from 2010 on, with better payments for mental health services and better access and benefit programs for parity of mental health services. So it's gotten a little better. That said, there's a shortage of psychiatrists, which is severe. There's a shortage of PhD and master's level providers, and of course they're not distributed well. That is one of the areas where I think telehealth is most easily applicable. And again, to the extent that the practice model changes and reimbursement changes, those things can be really quite effective.
And who are the leaders, would you say? I mean, obviously, there's probably a lot of them, and you can't mention them all, but who comes to mind as sort of leaders in this integrated approach?
So it varies. I see in Medicaid, some of the federally qualified health centers doing a very nice job of integrating mental health. I think the VA, in many ways, does a very good job of integrating mental health. I think Kaiser Permanente, again, some of the larger practices have been leaders in this area, and those who integrate payment and delivery of services have been the innovators here.
You talked about the fragmentation and why it's hard to scale these lifestyle intervention programs, because you don't capture people long enough to actually see the payoff. So if NPR decided to give me a diabetes prevention program today, I'll be gone by the time I might end up having any kind of chronic disease. Does that, is the misalignment, is the churn of the insurance? So typically a worker stays in a job 5 to 6 years, then they move on to somebody else's health insurance program, then we're all Medicare's problem come 65. Does that fragmentation work against trying to do this preventive kind of healthcare approach?
Absolutely. So, and Anand was speaking about this earlier, we do have to make sure we frame this correctly. So, a payer's perspective on an insured product with an employer with 20-25% turnover per year is very narrow. So the approach for a payer would be to stratify the population, take your sickest, manage that group, and everybody else who's moving into that sickest, we'll send you a pamphlet.
Sure.
And that's purely economically driven. That doesn't mean you shouldn't do it. And you may want to speak to that.
Yeah, and I'll just sort of tag along here. I think, Allison, that also speaks to the importance of multi-payer initiatives as well. That gets at the churn if everyone is doing it. So, for example, Bipartisan Policy Center, we had partnered with the Alliance for a Healthier Generation to launch the My Healthy Weight Pledge, which is essentially an insurance initiative to ensure that beneficiaries and employees get access to intensive behavioral counseling for the treatment and prevention of obesity. One of the issues was, well, why should a payer sign on when the average length of time an individual would be with that company would be 2 or 3 years. The payoff would be realized by potentially another payer. And one of the solutions there is geographically having multiple payers sort of buy into that. So that way, if you're getting new people in, they've benefited previously from the program as well. So I think that's one way of getting at this issue of, well, why should a payer invest in prevention when the benefits might not ultimately be accrued to them, but another payer. So when you have multiple payers, public and private sector, working alongside each other, I think you can somehow mitigate that.
One last point, which is in Medicare with STARS scores, and Medicaid with a variety of quality measures, and in the employers with HEDIS and other scores, glycemic control is measured and reported. So there is effort to manage people's diabetes or a stage of diabetes through that. That said, how many purchasing decisions are actually made around that is probably it's probably not a great effect on purchasing.
Got it. We're going to take your questions in just a minute, but I wanted to bring you back into the conversation, Paul. As you listen to this, can you think about any kind of transformative product that's in the works that you would like to develop when it comes to these diseases that we've been talking about?
Sure, absolutely. I mean, one thing that's certainly true is that the number of gene therapy programs in development is much larger today than it was even 5 to 10 years ago. You've seen some proof of concept, even though there are relatively few approved programs today in the US. It is speeding up, and for monogenic disorders, this is an obvious case where there's a possibility of making an intervention. Now,
what is a monogenic disorder?
Sorry, where you're just correcting one gene.
Oh,
so
okay.
you're effectively trying to solve it, low-hanging fruit
Okay.
from a gene therapy perspective. And I think the point that was made about it's true that we move around between different employers. So what's the incentive for your given employer on this day to solve this problem for downstream payers? The reality is some of these actually, because of the social determinants of health, are predominantly Medicaid populations. So that can be a case of sickle cell disease where we're working, obviously diabetes. So obviously from the government's perspective, it is the case that they have an incentive to ensure that there isn't further progression. Of course, the fact that our insurance is tied to employment is a weird legacy of World War II era wage controls, which is not super efficient. But that being said, there are many cases where it is sensible to cure it. I will say, in terms of cases in the past where we have taken a chronic disease and cured it, there has been some pushback over the short-term financial impact of that. So earlier this decade, we had Sovaldi and Harvoni, these drugs developed for hepatitis C virus, developed by Gilead. And the cost associated with that treatment regimen was really criticized. But the reality is downstream, you're saving a lot of money on liver transplants, things like that. So I think what you want
And the price came down.
Of course, and now it's actually the case that Gilead makes almost nothing from this program.
Yeah.
So it is the case that you want to make sure that there is that incentive for innovation, and you want to make sure that there is broad access. But again, the incentives are complicated. It is true that for any individual payer in a given state, it's a huge hit to their short-term budget. And I think that figuring out creative financial solutions to solve that problem, I think will go a long way towards ensuring that we actually get what we want, which is, again, cures, not just marginal improvements above the standard of care.
Got it. All right, we're going to take your questions now. Anybody want to be the first person? No? Okay, come on, you guys. Oh, over here. All right.
Hi, I'm Eric. I'm an MPH MBA student from Johns Hopkins. And I wanted to ask, when we talk about prevention, we always frame it in an avoidance of a loss in the future, or like to not develop obesity, diabetes, et cetera. And then we give them a solution of a lifestyle change as an effective intervention. How can we frame, when people that suffer from chronic illnesses are disproportionately already struggling in the present, financially, with time, et cetera, how can we frame prevention in a present gain instead of an avoidance of future loss?
Interesting.
Yeah. Anand?
Yeah, I mean, I think some of it is sort of word choice and how we frame things, and instead of saying disease prevention all the time, it should be about health promotion. And I think that gets to some of what you're saying. But I think when we talk about healthy lifestyles, whether it's increasing physical activity, eating more nutritiously, I think there are ways, both in the language that we use as well as the framing for the programs, to make it a little bit more attractive to people. So this is something proactive that they can do for their betterment, and not just to sort of prevent potential debilitating illness. So I think most people look at them in tandem, but I think your point is a fair one in how we frame some of the issues that we talk about.
And I might just add, we always talk about these things from a system level and an academic level, but to the person, who is the person that maybe needs to improve their healthful eating and get more exercise and focus on lifestyle changes. What we find in our very extensive work with patients and the public is what really matters to people is their family. And so if you think about the person maybe who's making lifestyle changes for themselves, also talking about the benefit to their family really matters. If it's a mother who has kids, these health changes can change the health outlook of an entire family, but you don't have to make it about the future, you can make it about the present. Like, you're not only, you're gonna feel so much better when you do these things, and so will your family. That would be the only thing I would add.
Yeah, right over here.
Hi, Michael Golinkoff. I'm with AmeriHealth Caritas, a Medicaid managed care organization. I wanted to comment on, sort of respond to his question, and because I also used to work in the commercial health payer space. There are ways to make the case for current benefit. I think to employers, you need to look at productivity. We need to get better at measuring it, but there's direct productivity. Someone with a heart condition or predisposed or pre-diabetic is probably going to have some difficulty.
Or depression or anxiety.
Right. So all of that, you can measure productivity, and people, it's harder to measure, but we shouldn't let the academic challenge discourage us. We should rise to it. But people will often will often state that the actual benefits to productivity exceed the medical cost savings. So that's one. For Medicaid, I would say that while there's a lot of political debate that it's not a bipartisan approach to trying to lower the Medicaid rolls, I think the best way to lower the Medicaid rolls is to make people more able to work. And so I think that there is a present day benefit to taking Medicaid recipients with chronic illness or vulnerable for chronic illness, provide them the best services, and get them back to work. And I think that's a present day. That's not a future medical cost.
Thank you. Anybody want to weigh in on that?
So we talked a little bit about social determinants, and I think poverty makes you sick, and poverty limits you in your ability to work, and poverty is, so in framing the question of what is the positive, if you're dealing with social determinants on transportation, education, access to food, and housing, you deal with those things, you reduce anxiety, you create better health. I think that's a very positive statement. You create social mobility. So all those things go towards a positive affirmation of how you can achieve health through solving other problems. And those problems are lifelong.
Yeah. Any more? Yeah, right back here.
John Rother with the National Coalition. Excellent panel, but I'm struggling with one part of the epidemic of chronic conditions that I don't understand, and that's the epidemic of suicide and depression.
Yeah.
I think we have a clear picture of what to do for cardiovascular or diabetes, but what can we do about what seems to be a growing phenomenon of serious mental depression?
Yeah. This is one of the reasons our roundtable is tackling this issue as we look at the broadest way of creating workplaces that promote health and well-being is the startling statistic, the 74% number that I cited to you. And, I can tell you among the roundtable members, almost everyone could talk about, an employee or a family member of an employee who had committed suicide. And it's, such a tragic wake-up call, I think, for all of us that we need to focus on, creating environments where people can bring their best selves wherever it is, to work, to church, to whatever the setting is, and that we help people know that it's safe to talk about, issues around anxiety and depression. And I think in this culture, especially in our companies, people aren't going to come to work and say, gee, I'm really depressed today. But we need to create environments where people can do that so that we can help people get what they need. That is, it is startling, and it is a wake-up call, I think.
I'll steal the lead of my fellow Davis on the panel of taking a line from another discussion yesterday, actually, during the lunch session, which is that there's this line that the greatest health crisis facing America is loneliness, and I think there's a lot of wisdom to that. I think that's something that's not amenable to a pharmacological intervention, but it is something where, as a health system, if what we're aiming for is health, we need to think creatively about ensuring that that is a problem that's solved as well.
Yeah.
So true.
All right, right back here.
Mission Cure, and we're working on addressing chronic pancreatitis through incentivizing improvements in patient outcomes. And so building on that mental health point, I wanted to ask about chronic pain. This is something that our population faces. I know it's a significant problem across the board. It has huge costs, and there's a lot going on now in terms of the opioid crisis to say what shouldn't be done. But are there similar types of interventions that are aiming to improve outcomes for people with chronic pain?
I mean, there are, as you know, Bess, there are tens of millions of Americans with chronic pain, and I think we have been saying for some time that there is a necessary response to the opioid epidemic. Simultaneously, we need to address the chronic pain epidemic, and they're not mutually exclusive. We need to do both at the same time, and I think part of tackling chronic pain is what you've heard up here. We need better evidence, better research, better treatments. So there's a research component. And then we need sort of the uptake by payers. So there are other evidence-based practices that can be offered. Providers need to be comfortable with these, know about these, and be educated and knowledgeable about these. So I think it's sort of a stepwise process there. There are people with chronic pain in this country who need to be on opioids, and I think sort of get careful, watching them carefully. There are others who, tapering opioids, is going to be important in a very judicious manner. But I think the meta point is we need to, in this country, be able to tackle multiple epidemics at the same time because there are people suffering from different things, sometimes overlapping, but it can be done and should be done.
I should point out earlier this month, the HHS came out with new guidelines to sort of course correct for what happened with the interpretation of the CDC guidelines. And the conclusion of HHS is that there are, name your millions, 3 or 4 million people out there who have tapered as low as they can go and still need opioids, which is something that is hard to say in the middle of an opioid epidemic, but that they presented a whole bunch of evidence that when you taper people quickly, you get suicidal ideation and a lot of other very bad things.
Right.
Anybody else want to weigh in on that?
So I think one of the things so I was with an investor group who said, we looked at a pain investment and we ran from it because so much was a pill mill or people who want to put implantable stimulators for all sorts of conditions. And you do find programs, and they're almost all in cities, which are really interdisciplinary programs which evaluate pain, look at sources of pain from mental health issues to physical issues to courses of treatment over periods of time, and really can be enormously helpful to patients, but there are very few of them.
I'm in the middle of profiling a woman named Pamela Bob. She's a 58-year-old woman who's a military wife, and she was born with a malformity that led to 16 different surgeries to try to correct it. None of them worked. And so after 18 years of surgery, she was left with a lot of scar tissue and nerve damage, and she was on a pretty high dose of opioids. She went through an integrative pain management clinic to help her do all these things. This is through the military, by the way. The military promotes acupuncture, biofeedback, anti-inflammatory diet, all these different interventions, and they all did help her. And so when I started the story, the headline was going to be something like, alternative interventions get patient off long-term opioid use. So I was working on the story, and about 6 months after I met her, I checked in with her, and I said, well, how are you doing? Because she'd been so happy. She discovered that eating a bag of spinach every day was helping with inflammation, and she completely overhauled her diet, and she was meditating, and she was feeling a lot better. When I checked in with her when I was about to publish the story, she said to me, I'm going to have to tell you something, Allison. I'm still on an opioid. And she was able to reduce it down. I think she said, her doctor told me 85% less. But she said without it, she still had too much pain. And I thought it was like, here's a woman who owned her health, took control of it and said, I'm going to do everything I can to feel better. And she did, but it wasn't quite enough. And it just, for me, was painted this picture of how complicated it is. Any more questions out here? Yeah, back here.
Hi, thank you for the presentation. I'm Jess Leifer. I work with a behavioral economics group that does research onto how and why people make the decisions that they do and why they fail or succeed to follow through on those. So I really appreciated the conversation about the diabetes prevention program. We've actually been working with CDC for about 4 years to understand barriers to enrollment. But you all might know that actually one of the biggest barriers is that 90% of the 83 million Americans with prediabetes don't know it, right? So I'm just curious to hear more from you all about what approaches you've seen that have been working to help people who don't have any symptoms of a chronic condition recognize that they might be at risk beyond sort of the public health campaign.
Well, all of the organizations, the American Heart Association, the American Diabetes Association, the American Cancer Society, all publish screening guidelines. What are at what age should Americans have which screening guideline? And what's tragic really is there's a whole bunch of people that are testing their cholesterol every 6 months and don't need to, and a whole bunch of people who have no idea about their risk for disease. And so, this is why employer-based health programs matter. 130 million Americans go to work every day. How can we make sure that the right screening programs are happening for employees and families? How can we utilize community centers? Those are things, because you're absolutely right. If people don't know they are pre-diabetic, if they don't know they have elevated blood pressure or elevated cholesterol, very low-cost treatments in some cases, especially for blood pressure, could really matter to their lifelong health. So I think it's an awareness and activation and going to the places, where, first of all, health is being paid for, and secondly, where people are, and making sure that these guidelines are being followed.
I think it's people's instinct to say, when you name a disease, it's people's instinct to say, oh, that's not me, that's somebody else out there, right? So just the idea that how do you get people to be aware that they're at risk of type 2 diabetes if they're sort of completely unaware?
I think this gets back to the earlier point of the importance of communication to prevention. It's communication to patients as well as to providers. And unless there are strong campaigns to educate both patients and providers, many people are not going to know, and they're not going to be able to enter that necessary set of activities that are needed to get their health under control. So I don't think we can underestimate the importance of sort of evidence-informed communication as well as education.
One of the biggest things for the man on the street, people who don't think about health and healthcare every day, and they're thinking about other things in their life, it comes back to their family. And what we have found in our work in communities and in extensive science-based market surveys is when you start talking about family history, keep track of the people in your family who, how many people in your family have had a heart attack or a stroke or blood pressure. Suddenly, the list goes on. So if you make it about something other than the doctor, prevention, nobody even knows what that means. Like, we know what that means, but average people don't know what it means. We know we have a really wonderful campaign tied to our Go Red for Women initiative, which is an initiative focused on helping women understand that heart disease is their greatest health threat, but it's done in a fun way. So we have Go Red Get Fit as an example, where millions of people through social media, are teaming up to lose weight, to understand their risk, including their blood pressure and other kinds of things that they can easily know and manage, and they're coaching and helping other people. So online communities, making it about family, making it about friends, takes away loneliness as well. I think these are the novel things, and the problem I see, and I've been around, a long time in this field, we make it too academic for the average person on the street who isn't listening to what we say. They're not understanding these terms, and so we've got to make it fun, make it about connecting with people, utilize technology and the power of community.
Paul, we heard Thomas say that he met with an investor group that ran from the idea of what can we do to invest in some kind of pain therapy intervention. I'm really curious. I feel like for a long time now, I've been hearing people say, oh, we need to develop a kind, given the problem with opioids, we need a different kind of pharmacological intervention, one that isn't addictive. Is that on the horizon, or is that pie in the sky?
Yeah, look, there are definitely development programs now for pain medications that act on different pathways. I think the reality is we need to diversify our approach. We need to make sure that we're really running the gamut of different approaches to intervene in this area. And I think that's true in other disease areas that are chronic as well, like Alzheimer's disease, where you've seen investment in a particular hypothesis, in that case the amyloid beta hypothesis, to the exclusion of other areas where there's promising research. And I think that's an area where I think we want to make sure that we're diversifying our investment dollars in a way that enables us to see which of these actually pans out. I will say that the pain's complicated. It turns out a lot of research has shown that if you remove all pain to a certain degree, there are a lot of health consequences to that as well in terms of joint pain. I mean, eventually damage to joints. There is actually a lot of value to having a certain amount of pain. So it's almost like titrating it to the right amount is actually the goal rather than the pure elimination of pain, if that makes sense.
I've heard some people say that pain is a construct. It starts with something real, but how we react and to the extent to which we feel it or to the extent that we're impaired by it depends a lot about what's happening in our mindset and it's a very complicated conversation. I know personally, my mother broke her toe and I said to her, Mom, how are you doing? She said, oh, I'm fine, it's fine, it'll get better. I never heard her complain once. And I was with my dad this summer and he got a splinter on a split rail fence and he asked me to get it out with the tweezer and there's this 75-year-old man looking at me, he said, dude, can you get this out with the tweezer? I put the tweezer in and he went, ah! He's just, like a child.
Before you even touched him with the tweezer.
And I thought, no wonder your hip replacement was so bad and Mom doesn't complain about her toe. You guys have a completely different relationship with pain. Anyway, I don't know what that point was all about, but any other questions out there? Yeah, back there.
Hi, thanks for this panel. My name's Stephanie Cousins. I'm with an organization called Brighter Bites. I just had a comment about education around in medical school about how we look at all the things we're talking about, whether it's nutrition, mental health, and pain. I think that these are three things that we're all talking about, that these contribute to chronic diseases, but they don't get as much marketing dollars or funding dollars as cancer. And I'm married to a physician, and nutrition was part of his capstone course for a couple of hours the last week of medical school. And so it might be a little bit of off topic, but I do think that education in medical school on the things that we're talking about today is vitally important, because when you go to the doctor, you go with all these different things that are happening to you.
Anand, did you get nutrition?
First of all, I love your organization, so thank you for all the great work that you do. It's been 20 years for me now, but you're absolutely right. I think in medical school education, we don't get enough of all of those areas that you mentioned. All these should be core components of the medical school curriculum. There should be questions on licensing exams. That's oftentimes what you end up being taught in classes. We've been doing some work in that space, but absolutely we need to do more nutrition, mental health, pain management. Ultimately, when you get into practice, this is what you see, and if we really want to serve the American public, then we need to be educated on that. So it's a really important point.
And Kaiser Permanente, of course, is launching a new medical school focused on prevention, and Bernard Tyson happens to be on my board, and he was mentioning last week the thousands and thousands and thousands of applications they have for like a really small number of spots. And I think they will hopefully demonstrate the power of a medical school curriculum, including all of these topics around prevention, and that, changing what's on the medical school curriculum is a long haul. We do a lot of work in the cardiology area around curriculum and licensure and those kinds of things. And, you got to find ways to just make it valuable to the doctors who are already licensed, to have them inspired to help train until a new model can be proven.
All right, thanks so much. Great panel. Thanks for coming. Thank you.